And I'm just going to explain the aims of today's webinar, and then I'm going to invite our President of BPOS, Dr. Ijaz Sheikh, to say a couple of words, and then I will continue the webinar. So just to set the scene, this webinar is titled, Should You Submit a CESR Application? What are the benefits of doing this? How can you do it well? And what pitfalls to avoid? So essentially what I'm speaking about is how to get your Pakistani postgraduate specialist ophthalmology training recognized by the GMC in the UK. That's what the aim of today's webinar is in one sentence. But I want to explain that I'm doing this webinar in conjunction with the British Pakistani Ophthalmological Society, and we have the president, Dr. Ijaz Sheikh, with us today, and he's going to say a few words about what BPOS is about, and then I'm going to tell you what motivates me to continue to be part of this wonderful organization. So over to you first, Ijaz, if you would like to say a few words.
Thank you, Sister Rahna and Dr. Adnan, for all your efforts to organize this session. You've been working through Sydney Institute of Visual Sciences, and we have history of collaboration for some time. Basically, in UK, there is a system whereby you have to follow GMC specialist registration to practice as a consultant, and Dr. Rahna Khan will elaborate on that. And it is part of the efforts of BPOS over the last 13 years to help Pakistani diaspora get up the ladder in a shortest possible way. And we are lucky to have around 230 members who are always willing to support and help in any regard which could be conducive to the progression of ophthalmologists who are in UK, in other parts of the world, especially in Pakistan, who wants to join the teams here. Thank you, and I think if there's any question at the end, we'll be happy to elaborate and clarify the situation, how we do help. Thank you. Over to you, Dr. Rahna.
Thank you so much, Dr. Ijaz. So when I first met Dr. Ijaz Sheikh, it was actually in Peshawar, just before the pandemic started. We were attending a conference, and this is when I learned about BPOS. And I was really excited that there was an organization for, like, my roots are in Pakistan, so my grandparents came from Pakistan, and then my parents moved to the UK, so I was brought up in the UK. But to keep that link and with my professional colleagues in Pakistan is really, really important. And this is the passion and the support that the group of ophthalmologists in the UK want to keep that link going with the colleagues in Pakistan. So we want to provide support for those who wish to practice ophthalmology in the UK, and also for those ophthalmologists based in Pakistan. We want to share the clinical governance skills, in particular research and audit, because this is what the feedback that we get, that the trainees in particular in Pakistan doing ophthalmology need a little bit more help, support, collaboration opportunities to push the research and the audit side of their curriculum, their CVs as well. So for colleagues in Pakistan, BPOS wants to do an action-based approach to address these needs. So what's this webinar about specifically? It's about the CESR, the Certificate of Eligibility of Specialist Registration. And my personal passion is to support women doctors, because I believe every single one of us has something significant to offer, and we are our character and we are our actions, right? So whether you are, whichever gender you are, you've got something to contribute. But I know that I think women in ophthalmology documents and the Royal College of Ophthalmology guidelines, and this is not an official Royal College of Ophthalmology endorsed talk. This is based on my personal interpretation of the guidance that's available in the public domain, and the lists that I show in today's presentation are not exhaustive, And the guidelines also change with time. I know this webinar is going to be recorded, so it's very important that those audience members who are listening do check the latest guidance, because things can change. Okay, so having said that, I'd like to move on to the next point. So CESR, this is the process by which doctors who have not trained in the UK in an approved training program can demonstrate their knowledge, their skills, and their experience as being equivalent to that of those doctors who are currently in the UK. We're just getting a little bit of disturbance. I wonder if we can mute everybody. Yeah, okay, that's better. Okay, so what are the benefits of doing a CESR? This is a big, heavy workload, okay? Doing a CESR is 5 years of your life that you will be collecting evidence to put in a portfolio or an evidence bundle to show that your experience is equivalent to that of a doctor working in the UK. So you need to make sure that you want to do this journey, okay? And you need to ask yourself, why do you need a CESR? Do you even need a CESR? What is your goal in life? Where do you see yourself in 5 years' time? So, for example, do you want a CESR just to, as a validation, to say, yes, my knowledge and my skills and my experience, I want to give my patients that confidence that I am up to date? Is that why you want to do a CESR? Or is it because you want to come and work in the UK and you want to get the GMC registration and license to practice in the UK, and then you can collect your evidence for your CESR while you're in the UK? Is that what your path is? So this is what you need to ask yourself, because you can apply for a trust doctor job or a fixed-term locum consultant post without your name being on the GMC register. So the CESR allows you to go onto the GMC register, and once you are on the register of specialist doctors, then you can get a substantive NHS consultant post, which is a permanent position. And once you have a permanent position and you've been in that position for 5 years, I believe currently that the rules are then you can apply for British citizenship. So it really depends on what is your goal. So that's really important to be clear about that. And then remember, I said this is a long journey and it's a huge investment of your time. And
this is again for all people who are.
Ma'am, can you mute the audience? It's disturbing a bit.
Sure. Okay, so at the end of that journey, when you're ready to submit your CESR, what should you have in your hand? So you need to have a PLAB, which is the equivalent of your medical school registration. You need to have evidence of English language, so they call that the IELTS exam. You need to have government verified identification, so your passport. You need to have a certificate of good standing with your the Pakistan Association, you know, the equivalent of the GMC in Pakistan, which is the Medical and Dental Council of Pakistan, I think. So you need to have a certificate of good standing, which is dated within 3 months of you submitting that CESR. And you need to have a CV that shows your professional activities within the last 5 years. And any documents that are not in English need to be translated into English and authenticated. I think in Pakistan, most official documents are probably in English, but you can correct me if I'm wrong. If you do have any important professional documents that are not in English, you need to remember that they need to get translated and authenticated. And then finally, all the evidence that you submit must be anonymized. There must not be any patient identifying information in any of the evidence and you need to check that before you submit it, the bundle, to the GMC. Once you submit it to the GMC, they will then pass it on to the Royal College of Ophthalmologists, who will assess the evidence bundle and make a decision as to whether or not your experience that you've evidenced is equivalent or not equivalent. So And if they say it's not equivalent, they will give you a list of reasons and what learning outcomes you haven't shown. So you have a very specific answer as if you were not successful, why you weren't successful. So once again, I just want to remind you that everything that I say in today's talk is my personal interpretation of the guidelines. And carrying on, what do you need to be submission ready? It's very important that you understand what evidence they want to see and that you submit the right evidence. Otherwise, you'll be wasting your time. You'll be collecting information on the wrong forms, the wrong type of evidence, submitting it, and then, being very disappointed at the end. So do the process right by understanding what the requirements are. And that's what I'm here to tell you today. So first of all, what the evidence is workplace-based assessments. Now, I know that you don't do those as standard practice in your institutions in Pakistan, or maybe you do. Does anybody do workplace-based assessments as part of their training?
Yes, madam, it's been introduced now by the CPSP. The junior fellows are requested to submit this work-based assessment form of the particular assessment. So it's being introduced now.
That's so good. And are they similar to the ones that you see on the Royal College of Ophthalmology website?
Ma'am, much similar to that, but it's not their levels of means assessment, and their parameters are a bit different. But they have started these things.
This is wonderful, really good. So this kind of evidence will be really, really good. But also, if you are specifically aligned and you want to do the CESR, there's no reason why you can't download the forms from the Royal College of Ophthalmology website, and then you are submitting the exact same forms that the assessors are used to seeing, and that will help your application, in my opinion. So I'm going to show you a few examples. Let me just go back to the previous slide. Here we are. So it's important, you've got, if you are using work-based assessments in your institution, that is very important, good quality evidence. But I'm going to tell you that you need 3 pieces of evidence for each learning outcome, and I'm going to go over that in more detail. You need to show evidence of audit and research, and the audit, you remember I said this is like a 5-year demonstration, because they want to see that your skills and experience are equivalent to the training program in the UK. So it's got to be over 5 years, and you've got to show that you're maintaining those skills and that the skills are up to date. So audit, try and do 1 audit every 6 months, for example, across the different subspecialties. So a glaucoma audit, an oculoplastic audit, and so on. It's not a hard and fast rule that you must have 1 audit in every subspecialty, but you've got to show that you're doing regular audit. So minimum one a year at least. And then if you do them all in 1 subspecialty, that will make it harder for the assessors to pass that particular learning outcome. They want to see general ophthalmology experience. You need to understand the clinical governance in the NHS. So you don't have to work in the UK, but to show equivalence for CESR, you need to understand the specific NHS policies. For example, duty of candour, where if a mistake happens, you explain it to the patient. You don't try and hide the mistake, for example. That's duty of candour in a nutshell. So you need to be aware of these GMC good medical practice guidance documents, and show evidence that you understand it and will incorporate it in your work. The other thing that's very particular to the UK and the NHS is diabetic retinopathy screening, safeguarding policies, notifiable diseases, and certificate of visual impairment, CVI registration. So all of these things are guidelines on the Royal College of Ophthalmology website and in the GMC website. So you need to be familiar with these things. And then we've got hydroxychloroquine screening, for example. So these are all Royal College of Ophthalmology guidelines. You need to know these. And I already mentioned duty of candor. And finally, you need to understand the appraisal and the revalidation process because they want to see evidence of maintained skills and that you are showing that you are employing good medical practice. So you're keeping your knowledge skills up to date. You are engaged in safety and quality activities such as audit. You are a good communicator and a good team player, and you take feedback from your colleagues and from your patients, and you take that into consideration and improve if that's relevant. And finally, that you probity, you act professionally and ethically and morally. That's the fourth domain. So that's the revalidation process covers all of those things, and they want to see evidence of this. So I'm going to explain in detail each one now that I've covered. So workplace-based assessments you're familiar with. And the really, really main important point here is that to show evidence of knowledge, skills, and like surgery, you need to provide workplace-based assessments, ones from your institution. You can also use reference letters on hospital-headed paper from a senior clinical supervisor who is willing to write down that they have observed you doing the following skill and what their assessment was, and sign and date it. But the two very important points to note with regard to workplace-based assessments is, number one, triangulation of evidence. So a triangle has 3 points, and they want to see 3 pieces of evidence for each learning outcome. So that could be 2 workplace-based assessments, for example, 2 case-based discussions, and 1 letter from your senior colleague. Or it could be 2 workplace-based assessments and 1 course certificate, if that's relevant, depending on what the learning outcome is. Or if you've done the Royal College of Ophthalmology exam, the FRCOpth, that is 1 piece of evidence for about 1/3 of the learning objectives. There's about 180 learning objectives that you have to show evidence for that are spread across the 4 domains. And you need to show 3 pieces of evidence for each learning outcome. That's what triangulation of evidence means, and the assessors will be looking for that. If you only submit 1 piece of evidence for 1 learning outcome, that will not be enough because it doesn't show them evidence of maintained skills. That's why, right? They want to see that in the last 5 years, you may have started with simple cases and then you've built up to more complex cases. They want to see evidence of that. And that's why triangulation is important. Okay, so I want to show you an example of one of the learning objectives. I mentioned to you there's 180 learning objectives, and one of them is here, CA3, competence in glaucoma, visual field by confrontation. That's the learning objective. So there is a document that you must, if you are interested in doing CESR, you must get this document. I'm going to show you the reference at the end. It's on the Royal College of Ophthalmology website. And it lists all 180 learning objectives, and then it lists exactly what evidence they want to see. That's how detailed it is. So it's so important to use this information. So for this learning objective, visual field by confrontation, what they want to see is ask a consultant or a senior colleague to observe you performing visual fields to confrontation, for them to provide feedback on your performance and document this. Now, they've even told you which form you need to submit. It's the College Clinical Rating Scale, CRS, Clinical Rating Scale number 3. And it's titled Visual Field to Confrontation. This is the form that they want you to submit. Or you can submit a signed letter typed on headed paper. But different work-based assessments should evidence the ability to detect different types of visual field defect. So it's very important that you read each instruction carefully. If you just submit 1 letter from your consultant to say, I have watched Dr. Adnan perform a visual field confrontation, he detected a left homonymous hemianopia accurately, and he did the the assessment correctly, signed by consultant supervisor, and you submit that, the assessor will say, very good, but I haven't got triangulation of evidence, so one piece of evidence isn't enough to tell me that you definitely have this skill. I need at least 3 pieces. And secondly, I've only got one in one point in time. So if you did that 5 years ago, how do I know that you're still maintaining that skill? So I need at least 2 over a time point. I need the correct one, and I need triangulation. So the third piece of evidence could be that you possess the exam. Now, the FRCOpth is not mandatory to pass CESR, but it helps immensely. And I can tell you that up until recently, if I was giving this talk, I would say nobody has been successful in passing CESR who didn't have FRCOpth. But recently that has now changed. I think we've had 2 CESR applicants that didn't have FRCOpth, and they were able to demonstrate all of the evidence for all of the competencies to a satisfactory level. So I know that's a very common question that comes up. Do I need to have FRCOpth in order to pass CESR? And the answer is no, but it makes it a lot easier because it gives you one of the pieces of the one of the points on the triangle for about a third of the learning objectives. And then you just need to provide 2 more pieces of evidence over 2 different time points. And with this example, you might have detected one left homonymous hemianopia, but I want to see, as an assessor, I want to see that you can pick up different types of visual field defect. So I want to see another field defect that you've mapped out as well. So, and they specifically tell you, see, the evidence of ability to detect different types of visual field defect. So if you just submit in your bundle 3 of the same homonymous hemianopias, I'll be like, what about the other visual field defects? I don't have any evidence as an assessor that you can do that. So make it easy for yourself by making it easy for the assessor to pass you by exactly doing what they ask you to do and providing the exact evidence that they're asking for. I'm going to show you one more example. This is PI4. PI stands for patient investigation, ocular angiography. You must be able to interpret a fundus fluorescein angiogram and an ICG. A signed letter on headed paper from a consultant or a senior colleague providing feedback and documenting your performance can be given as evidence. Case-based discussions may be provided. Case reports or histories can also evidence this, and course certificates can provide evidence. If you go to a fluorescein angiography interpretation course and you have a certificate, that will be one piece of your 1 point on the triangle. Then a case-based discussion and a case report that you've written. And possessing the FRCOpth exam will also provide some, but not all, of the required evidence because it's only 1 point on the triangle. So notice the language of the Royal College of Ophthalmology curriculum, PI4, and before in the visual field example, we had CA. CA is clinical assessment and PI is patient investigation. So you need to, the other thing that I want to tell you, I've chosen patient management visual standards for driving as another example from the retina section. It's also in the glaucoma section. So this is another thing, you need to be familiar with the UK rules relating to ophthalmology. So can your patient with visual impairment drive? You need to know what the visual standards for driving are in the UK in order to show the evidence, okay? Now I've noticed, Dr. Adnan, how much time do we have left?
Ma'am, in this session we got 10 minutes left, but we have also planned another webinar which will be about 40 minutes more. So if it's ended, we can start another webinar. I will share the link with the audience and with you as well. So it's we got a plenty of time.
Okay, that's fine. So we'll, in 10 minutes, when it cuts off, we'll all just rejoin again.
Yes,
okay, that's great. So learn the language of the curriculum, be familiar with what these terms mean, and it'll help you to collect your evidence more effectively. Clinical assessment, patient investigation, patient management, and so on. You can see them, they're all on the Royal College of Ophthalmology, website, okay? The next point is the submission bundle. I just want to explain to you this big bundle of evidence that you will be collecting. What does this look like? First of all, the basis is you're proving that you are a good doctor and that you practice the skills of good medical practice. And that is defined by these points here. I'll just give you a second to read the bullet points. If you're watching a recording, you can pause at this point and just take these bullet points in. It's all about putting patients at the center of your practice. And next to it, I've written domain 1, which is evidence of knowledge, skills, and behaviors. Then domain 2 is evidence of involvement in safety and quality improvement work, which is your audit, research, clinical governance. And then domain 3 is about communication, partnership, and teamwork, and it's showing evidence that you have good communication, you work well in a team, and that you partner with both patients and colleagues. And maintaining trust is about working with the ethics and integrity that we talked about earlier. Okay, so what type of evidence? Now I'm repeating this because it's so important. Workplace-based assessments, there are different types for different learning outcomes. You must use the right type of workplace-based assessment for the specific learning objective. And it's clearly listed, as I've shown you, in the document in the college website for CESR guidance. Okay? It's so simple. You just have to follow the instructions and don't change it. So I've had a situation as an assessor where somebody has submitted the wrong kind of form, and I try my best to take the information that I can. For example, it says visual field to confrontation, you must do a clinical rating scale, a CRS, but say they've submitted the case-based discussion instead. So I try my best to get the information, but it just makes it so much easier if you use the right form, and it could be that it's rejected. It depends on who the assessor is. And it says, oh, you've used the wrong type of form, so I'm not going to assess this. You need to use the right type of form. The other thing to do, remember, is avoid bunching. Bunching means when you are just the date of the assessment is all bunched together. You need to spread this out. The assessor will notice. And also, if you just get one person to sign the majority of your work-based assessments, it will be rejected. You need to get a variety of people, colleagues that you work with over time to sign them. It looks suspicious if you just get one person, because that person could be your best friend and they could just be like signing all your forms. So you need to get a variety of people. And you know what? Healthcare professionals, not just doctors, so orthoptists, opticians, other eye care professionals that work with you, there are certain forms that they can sign as well, and the assessors and the college love this multidisciplinary working, and that would be very, very positive to see that you as an applicant are working in a multidisciplinary team approach, and you are getting your other eye care professionals to sign some assessments too. So testimonial letters by a senior colleague, we've already talked about, but we have different quality of letters, strong letters versus weak letters. So a strong letter will have the date, it will have the details of what was observed, it will have some comments about your performance, so with examples and feedback. That makes it strong. A weak letter, it gives us no information, just this doctor performed this assessment on this day, very well done, excellent. That doesn't tell us anything. So, you know, that's something to think about. Certificates from courses attended is another type of evidence. The exam, I've already talked about. And if you go to attend departmental meetings, keep the minutes of the meeting. If you're presenting in that meeting and it shows on the agenda, that's excellent piece of evidence with regard to domain 2, quality improvement work. And if you give a presentation, submit the slides, but importantly, try and get feedback on the presentation and submit that with the slides, because just submitting slides just gives us a small bit of information. But what did the audience get from your presentation? Try and capture that and submit that too. Okay. I keep wanting to remind you that this is my personal opinion. And for domain 1, I just wanted to highlight how many learning outcomes there are. So in domain 1, this is about knowledge, skills. It's split into 2 sections, section A and section B. Section A is by subspecialty in ophthalmology. So we all know the 8 different subspecialties in ophthalmology, 9 even, and this is how many learning outcomes are in each one. Ocular plastics has 14 learning outcomes, and so on. You can see on the slide. Emergency ophthalmology has 8 learning outcomes. You need to show triangulation of evidence and evidence of maintained skills for each one of these learning outcomes. Then in section B, research, there are 8 learning outcomes that you need to show evidence for. One of these is doing the GCP course. You can do that online, free of charge, print off the certificate, that's one done. Teaching and training, making referrals, record keeping. Look them up on the Royal College of Ophthalmology website, and it will tell you exactly clinical governance, health and safety, personal health, and appraisal. So the personal health one, for example, is a statement that you look after your health.
Ma'am, can you
just muted. Yeah, I wasn't sure if it was a question. What I'll do is I'll take questions at the end. We have 1 minute. So I'm just going to finish this section, which is basically showing you how many learning outcomes there are for each of the domains. So the final domain is domain 4, showing respect for patients. There are 8 learning objectives. Treating colleagues fairly. There are 20 learning objectives there, and acting with honesty and integrity. Now, it was outside the scope of this presentation, fixed every single one, but please do go and look at the guidance notes. They are available on the Royal College of Ophthalmology website. It's Appendix B that you're looking for. It's the application document, and it lists all the learning objectives and which evidence is required for each. Please remember to familiarize yourself with the curriculum and use the correct workplace-based assessment forms. This is the biggest piece of the biggest tip I can give you as an assessor. If you use the correct forms, it will make your life and my life as an assessor a lot easier. Now, the forms that you are using internally that Dr. Adnan described are also very good pieces of evidence. But at least have 1 or 2 of these forms downloaded from the college. Do exactly what it says. Assessors are looking for triangulation of evidence and maintained competency within the last 5 years with progression in complexity of cases. So just pretend you are an assessor when you look at the evidence that you're putting together. Okay, so welcome back. Specific things to be aware of. With regard to the CESR application, you need to show that you've done 350 cataract surgeries. You need to show 10 ROP screenings, 20 squint muscles. You can use a wet lab if you have one in your organization to show evidence of a learning objective, but specifically only for corneal bluing and anterior chamber paracentesis. Useful courses to bear in mind to sign up for and keep the certificate to submit in your portfolio: a refraction course, safeguarding course, the GCP course, which is one of the research learning objectives. GCP stands for good clinical practice, and everybody who does research needs to do this certificate annually because it's about research ethics. And then there's one called the European Driving License for IT skills. So that there is a learning objective on IT skills, so that's a good piece of evidence. Remember, I mentioned multidisciplinary team working. Attend low visual aid clinics if you have them in your organizations, and do a reflection or a case-based discussion with regard to a patient who you listed for certificate of visual impairment. Now, if these things are not available to you in Pakistan, then you need to perhaps write down a hypothetical situation of this is a patient who with this level of visual acuity, and this is how I would suggest that they need a certificate of visual impairment registration. So showing that you're familiar with the process. That's that's where it's useful to be working in the UK. But these are just a few things. And if you're not working in the UK and you do want to do CESR, you can find ways to get around this. And getting advice from people in BPOS for these specific ones is a useful thing to bear in mind. Signed letter from your orthoptist colleagues. Do you have orthoptists working in Pakistan in the eye clinics alongside you?
Yes, yes, madam. We, in our institute and also in a private setup, there are orthoptists. Also, there's a Lovinet special clinics and all of the setups of optometry. We got them, alhamdulillah.
Okay. Yeah. No, please excuse my ignorance. I have been to Pakistan eye clinics to visit, but I've not worked in Pakistan eye clinics, so I'm not 100% sure about some of the setups. So I really appreciate you being able to tell me, and apologies for my ignorance in this area. So signed letters from your orthoptist colleagues to evidence that you can do a cover test and that you can interpret the results of a HES chart. Then we've got a CPD diary. So keep a diary. That electronic one is best, showing that you are getting 50 CPD points per year as a minimum. And those have to be spread across 4 categories: internal educational activities within your department, external meetings outside of your department, self-directed CPD, when you read a journal article and you write down what you learned from it and how it will change your practice. And then finally, management leadership type experiences or courses. That's the 4th domain. So you need to show across these 4 categories a minimum of 50 points per year. That's another requirement. So going into a bit more detail, the 1 hour of learning equals 1 CPD point, and you need to show 50 per year as a minimum over these 4 categories: local, regional, and that includes basic life support, annual course, so that if you go to a course that's a half day, that's 3 hours CPD there. So don't forget your mandatory training is also CPD points. External academic meetings, including submission of a poster or a paper to a meeting, that's CPD points. Self-directed and management leadership. I want to say a few words about the personal cataract surgery logbook. It's very important to show 350 minimum cases. Oh, and now I said 5 years, but for cataracts, I believe they will allow 7 years because it's 350. However, in the last consecutive 6 months of submission, you need to do an audit of your last 50 consecutive cases. Now, the audit has to show details: the date of the surgery, the hospital number, the pre-op visual acuity, the pre-op pathology, any medical history or comorbidity, because you want to show, is this a basic cataract or a complicated cataract? Then you've got to list any intraoperative complications, any post-op complications. What was the best measured post-op visual acuity, and what was the spherical equivalent refractive aim, and the actual spherical equivalent? So how much did you deviate? Now, this link at the college website, Learning Outcomes, specifically this one, will give you more detail about the personal cataract surgery logbook, okay? This usually creates a lot of questions, but make sure this audit is separate from your other audit experiences as well. They expect this as a standalone audit, and it should be submitted as a PDF file, and it includes, you've got to write it up, your last 50 consecutive cases. So the logbook details I told you. Now this is your personal cataract audit. They want to see that you look at your results and that you benchmark against what is expected for your level. So if you're a trainee, there's a different benchmark. If your cataract surgery case is complex, that's a different, your PC rupture rate is going to be higher if it's a complicated patient with pseudoexfoliation and a small pupil. And if it's a standard, no extra risk cataract surgery, your PC rupture rate shouldn't exceed, 2% or whatever the National Audit Ophthalmological Database, the NOD database states. So that's something, again, to look at. Okay, so how to get your CESR, the timelines. Make the intention, get support from your seniors, and start a skeleton folder with all of the chapters. Look at the spreadsheet, each learning objective, evidence that you need, and set a target date for when you're going to get it, and review this monthly. So if you are currently working in glaucoma, or you know that you're going to be doing 6 months of glaucoma in the second half of the year, plan. Look at what learning objectives you need to show, look at what the evidence you need to provide, and plan it in your diary so that you know you're on target, and review this every month. For example, if you're doing pediatric ophthalmology, you know you're going to be timetabled to attend squint theatres. So identify all the squint-related learning objectives, download the correct forms, arrange it with your senior to sign them off, and make sure that you timetable yourself in to push yourself to try and get that target. Even if you fall short, this will help you move forward. And then, if you haven't quite made the target that you wanted, you can plan next time, okay, how am I going to achieve this? But if you don't do any pre-thinking, it'll be very, very difficult for you. And say there's times that we all have when surgery is quiet. In those times, you can use that very productively by, I've lost my slide, hang on. Oh my goodness. Sorry. Here we are. Okay. Open speed now. How to get a CESR, CPD, cataract surgery. We've talked about common pitfalls. So we're nearly at the end. We're going to talk about common pitfalls, but this is what I was talking about. How your timelines. So when it's quiet surgical times, do some audit work, do some research work, collaborate with your colleagues, do some teaching, get feedback on teaching, reflection on teamwork examples, attend departmental meetings, read an article, and write a letter in response to the article, and get yourself a quick, easy publication. I'll tell you a story. Once I was off work sick. I had a day off because I had the flu or something, and I read a British Journal of Ophthalmology, and there was an article in there, something, I can't remember what the article was, but because I was at home that day, I just wrote a letter in response to that article, like my thoughts, and they published it. So, sometimes they publish your letter, and then that's like, oh yeah, it's something, it adds to your CV. It shows that you're engaged in literature and that you keep up to date and you read. So, try and do those kind of things. So keep your cataract logbook up to date. Okay. Map out 4 to 5 years, or review what you have at the moment and decide how long it's going to take you to get the remaining evidence that you need. One method is to try and do 6 months in each subspecialty if you can arrange this, plus emergencies and general ophthalmology, and collect your evidence. Don't forget about the PLAB and the ILETs, because that's important as well. And consider doing FRCOpth, but it's not essential. And they are doing Part 1 in Pakistan now, so that's good news. So you don't even have to come to the UK. The other thing that you might want to consider is the financial implications. You might want to start saving, because to submit a CESR costs money, right? There's a fee for everything. So I just did a quick calculation. I think it's £1,676. If you divide this by 4 years, you're saving £419 a year, which equates to this number of rupees. So it's just something to bear in mind. Common pitfalls in the process. I'm going to tell you, I've got 3 slides and then we're coming to the end. This is the common mistakes that people make that result in failure. I'm going to share these with you so you don't make them, okay? The practical skills session, venous cannulation, people find it really hard to find the opportunity, because trainees in the UK don't do venous cannulation anymore, because the patients often go to the phlebotomy department and have their blood taken there. So they never have the opportunity for somebody to watch them do venous cannulation and sign them off. The other one like that is Botox and the lid hygiene and the aqueous vitreous, the tap. So these are ones that they find difficult to provide evidence for because of lack of opportunity. So I just wanted you to be aware of this. The Royal College of Ophthalmologists did an audit on the last 10 consecutive CESR bundles that were submitted. And these ones showed up as the ones that commonly had the problems. The other one that the candidates find difficult is the general medical examination. When I say difficult, they find it difficult to show evidence for this. So if you can get a senior colleague to watch you do a general medical examination and record that on signed hospital letter-headed paper, that is your evidence. Now, corneal gluing is notoriously very difficult to get the opportunity and then get somebody to watch you because it's so few and far between. So like a corneal ulcer perforation, thank God, is rare, but how do you show evidence that you can do corneal gluing? Well, you must do a DOPS, that's the correct work-based assessment. DOPS stands for Direct Observation of a Practical Procedure, or Practical Skill, DOPS. And you can do one of the two required in a wet lab. So that's a little tip there. Other wet lab ones, AC paracentesis, don't forget to do your basic life support course. People forget that came up as read in the audit of the last 10 CESRs that was submitted. Research to do, remember I told you about the free GCP course. Sign up to do one online. Just Google it. You'll find one, do it, download the certificate. Okay. Slide number 2, common pitfalls. People forget they need to do a minimum of 10 ROP screening, and then they're trying to do it at the last minute, and they're bunching, and the dates are all the same, and the same person signed them off. So just try your best. I mean, that's fine. You might be doing pediatrics for 6 months, and you might have one supervisor. That's okay. But don't forget about it. And you also need to do 40 retinal laser procedures. That can be PRP, retinopexy, macular laser. Don't forget to record them. You need to show that you've done 10 to 20 B scans. So these are logbooks that people forget to keep because they do them all the time, but they forget to take the patient sticker and write down the evidence and keep the logbook. And then somebody's got to sign that to say, yes, this is true, you know, the consultant you're working with. Subtenons, intravitreal injection, laser safety, laser induction, this was often missed. So if you have a course in your hospital for laser safety, make sure you remember to do that. And then with regard to contact lenses, this came up as a red flag for lots of people as well. And then diabetic retinopathy screening service, allergens, immunizations, drugs in pregnancy, prophylaxis. The learning objectives related to these were flagged in red. Okay, number 3. Angiography, electrophysiology, and bone scans. So the learning objectives related to these, the evidence that they were presenting wasn't sufficient for the assessor to sign them off. So be aware of these ones. And then obviously surgical skills, trauma repair was difficult because these are opportunistic, you know, they come in the middle of the night and they're usually out of hours. So people found it difficult. Don't upload evidence that's more than 5 years old. It won't add any weight to your application. I think that cataracts is the exception to this rule. 350 cataracts, you can have them within a 7-year period instead of just a 5-year period. Don't forget your CPD diary, 50 points per year, and 1 audit across a range of specialties. I had to fail one of the CESR bundles that I was assessing because they only had like 2 audits and they were both in medical retina. So there was no evidence to show audit across the subspecialties. So you need to have, I think, at least 4, and that doesn't include your personal cataract audit. Okay, so this is the end of the talk, and in summary, the CESR is achievable if you stick to your plan. Research and think about the type of evidence you will need and begin to gather your evidence well in advance of making your application. Otherwise, it will become a very stressful, very difficult process. Make sure that your evidence is of the highest possible quality and is current. You will be assessed against the most recent curriculum, and ensure that the evidence that you collect demonstrates your competence across the whole of the curriculum, not just your subspecialty. Okay, so we've got a few more minutes until I have to go at 10. So that's, I've got 2 minutes if there are any burning questions at this point.
Yes, madam. I would like to ask, you said we should record these evidences by downloading the form. I would like to ask, from whom we can ask to sign this form. For example, in case of a supervisor in Pakistan, we don't have a FRCOpth consultant.
That's fine. As long as it's your supervisor, they do not have to be RCOpth member. They just have to be registered in the country that you're practicing as a senior, as your supervisor. So if they're your supervisor can sign your form. I specifically checked this point because there was a lot of confusion about this. Does the supervisor need to be a college member? Do they need to be FRCOpth? The answer is no.
Ma'am, second question is, we need to have a training experience, so these all evidences in UK, or we can collect this evidence in Pakistan, and on the basis of that we can apply on CESR Pathway?
You can, Pakistan, you do not need to come to the UK to collect the evidence. This is the whole point is you're showing that your experience in Pakistan is equivalent. So they don't expect you to come to the UK to collect the evidence. You collect it in your place of work, in your country.
Okay. Ma'am, you said FRCOpth is a method of doing, it will provide you edge over the other candidates who are applying for the CESR Pathway. So is there any other exam which provide us a benefit in the CESR Pathway, like FRCS Glasgow or Edinburgh?
So let me just clarify, Dr. Adnan. FRCOpth is not mandatory to pass CESR. It is helpful because it will give you 1 point of your, in the triangle, I talk about each learning objective has to have triangulation of evidence. The FRCOpth is 1 point on that triangle for 1/3 of the learning objectives. That's why it makes it easier for you to get your required evidence, but it is not mandatory. And I have got examples of successful candidates who have successfully achieved CESR without doing the FRCOpth exam. So just like the FRCOpth doesn't officially give you, a definite advantage, no other exam does as well.
Thank you, madam. I think some audience can have a question. I don't think so. Ma'am, I got another question, if you allow. There was some question, for example, if we came to UK by any means and got a GMC registration, but we didn't get a CESR Pathway, so can we practice as an ophthalmologist there, or we can't?
If you are successful, if you apply for a job and you get a locum consultant job, and they give you the job, you can practice without being on the specialist register as a locum consultant, which is usually a fixed term position. That's why most people want to have more security in their job, and that's why they then decide to go for the CESR, because that allows you to be on the specialist register with the GMC, and you need that to apply for a permanent consultant position.
Okay, ma'am.
Does that make sense?
Yes, madam, I got the point.
You can also apply for trust doctor positions, but it depends on the hospital. Some hospitals advertise a job and they say essential requirements must be on GMC register. But some hospitals, usually through, I guess if they've got big waiting lists or something, maybe Dr. Ijaz Sheikh has got more practical experience in this for this question.
I don't think it is very specific unless it is a tertiary ophthalmic hospital.
Mm-hmm.
One is on the GMC register, that is sufficient, but CESR is for specialist registration to become a substantive consultant. That is things, but I know colleagues who have been locum consultant without doing the CESR, and they do a lot of cataract surgery in different areas. So that is not a requirement. And from my point of view, I never did FRCOpth, but 15 years ago, I did my CESR. I was amongst the first few who managed to do it. But since then, life has changed. It's not easy, but that is one thing I can say. Support is available, and we can manage and support anybody who wants to do this pathway, but it needs dedication. And as Dr. Rahna Khan says in her website, Success with Grace will be enabling you, motivating you, and inspiring you to achieve the best. Because there's always room at the top. Whatever you do it with dedication and you'll be successful.
Thank you, sir.
The very nice words to maybe bring the session to a conclusion.
Yes, ma'am.
Just because I've got a meeting at 10, so I need to go.
Okay, ma'am.
Okay.
Thank you so much. And thank you to the audience. If you do have any questions, please submit them to Dr. Adnan, and he will email them to me. I'll be very happy to respond via email.
Sure.
All right. Thank you so much. I'm going to log off now.
Okay, madam. Thank you.
Have a good rest of your evening, everybody. Salam.
Salam.